The American College of Physicians has one of their committees that looks at performance measures, uniquely called the Performance Measure Committee. There are 12 of us, 11 of the members who have experience in evidence-based measures and quality measures. And then there is a chair that is our coach or our guide. And we published a paper that looked at performance measures that are out there for depression, screening, treatment, and follow-up. We looked at 8 different measures. We supported one of them because we only support measures that are found to be clinically relevant, valid in how they're measuring what they're measuring, like how good are they at doing it, steeped in evidence, and then tested at whatever level it's supposed to be deployed. So if it, for example, has only been tested at a health plan level, but you're going to use it to measure an individual physician, that would not be something that we would support. And we looked at all 8 of the measures. We are supporting one of them, which is a suicide risk assessment, because it met all of those metrics. It's very clinically relevant and important. It was methodologically sound and had good evidence behind it. And the others, we go through the paper and explain why they're imperfect measures and could possibly lead to harm rather than the outcomes that everyone is looking for. I think we don't deny how important identifying patients who might be suffering from depression and getting them as treatment as quickly as possible is. It's just that we need to measure the right things in the right way so that it is scientifically valid. One of the reasons I actually really enjoy being a part of this committee is the work that we're doing. I think physicians are used to taking tests or having to meet metrics to indicate that they're up to date and providing good care. But there's a lot of frustration in imperfect measures or measures that are sort of taken out of convenience that don't really highlight the quality of the care that's given. And one of the things I hope to highlight with this paper is that the ACP is really trying to serve as a conduit between the physicians and organizations that are creating these measures to try and have a second round or a new round of performance measures that are really valid, that we can trust and put faith in. Because if they're valid and trustworthy, we can say, I can use this as a metric for my care. I can look at a report card of these and know maybe where my gaps in performing well are and use that as feedback to improve how I deliver my care for the patient, which obviously improves the care for all patients. The other thing I think I would like the physician audience to take away from this is that they could use these published articles that we hope to create with the Performance Measures Committee, take them back and use them to advocate with insurance companies, state agencies, their organization, and, you know, as a guide to say, we're not against performance measures in general. We just want them to measure what they're supposed to measure in a valid and accurate way. And this almost provides a blueprint for how to do that. And a primer, if you will. We walk you through why certain of the performance measures we looked at were not valid and why we could not support them. The 8 of them looked at everything from preventative care, which was screening and then follow-up, to the suicide risk assessment at new diagnosis, or if someone had a recurrent episode of major depressive disorder. And then the rest were really on management, follow-up to see if they were progressing towards remission. There were 2 of those that looked at 6 and 12 months, and then 2 more that sort of mirrored that, which looked at, did you reach remission for your patient at 6 to 12 months? And then, you know, in looking at the metrics, just to summarize, the majority of them had either not been tested at the level that they were going to be deployed and used as a scoring system for quality of care, or they just weren't valid. I'll give you a really good example. I don't think anyone would argue that screening for depression and trying to have a follow-up plan for that patient is really important. But the metric itself can't capture what you're looking for. So follow-up, might not be necessary. If I'm a new mom and I'm exhausted taking care of a newborn at home and I have an annual depression screen at my physical, there's a reason that I'm so tired. So the screening questions might be positive that I'm tired and I don't really have interest in doing my normal activities, say painting or running or seeing my friends, because I'm really just all incorporated with a new baby at home. That won't need a specific follow-up per se, other than touching base with my patient to make sure they're doing well, versus someone who has depression. It's either a recurrent episode or we know that this is the diagnosis and we're going to follow them up with treatment. Another issue with that type of metric is right now for mild to moderate depression, one of the first line therapies is psychotherapy or talk therapy. And patients don't need a referral from their doctor to do it. They can find someone online who takes their insurance. So we might have a plan for that, but there's no check the box mechanism for the insurance company or your organization to say, okay, we hit this, you provided good care. They would have to read your notes, and that's a cumbersome metric to ask a physician to report on. They would have to go through their notes and prove that for their patients. Another example of why some of these metrics really didn't meet the bar that we set were the ones on remission, either working towards remission or did you hit it? And I'll just give you a really easy example. There were random times chosen, 6 months and 12 months. There's no data that supports that 6 or 12 months are these magic numbers that say a patient should reach remission or be on their way at this point. It sort of, I don't want to say punishes you, but it's a harder bar to hit if you have a higher patient population with resistant depression. And we don't want physicians to avoid taking those challenging cases because they're worried that they're going to be penalized on quality metrics. And then even if I don't hit remission with a patient, which would, be a score in the PHQ-9 of 5 or lower, but I get their score down from 17 to 6. That is really a significant improvement in quality of life, their symptom burden. That does matter. So we found that these metrics really did not have the scientific basis to say 6 and 12 months were magic numbers, and they also weren't tested at the level of attribution. So the antidepressant medicine performance metrics, it's that there are a lot of caveats that go to this. So first of all, we are not the medication police, and we cannot force a patient to take a medicine. There are medication interactions and some adverse effects of antidepressants that we commonly see, one of which is decreased libido, which could affect relationships with their partner and further affect quality of life. So they may start a medication and then not continue it. I think a metric of did we prescribe a medication that was appropriate for the patient in front of us is something that could be measured more easily from your electronic health record. But if they don't go and pick it up at their pharmacy or they decide they do not want to take it, that is free will for the patient and not something that the physician should be penalized for. So that was the one that we supported. It is, and I'll walk you through why. So it's a validated tool that can be used. So it already had evidence supporting its validity. It can be easily deployed. It is something that when you use it in your electronic health record, you can even tag on a code to it, reducing the burden of how do I prove that I did this? That's a really easy quality metric to say, there's evidence for this. It's a validated tool. It reduces risk to the patient, and we can really easily grab the data without pulling the physician out of the room with the patient to kind of go through notes and read notes. Let's leave them to taking care of the patient, and we could pull that or extract that out of the electronic health system. So most of them didn't meet it. One of our tables, it is a figure that's on page 4 of the article. When you look down the entire line, what you see is that we really did think everything was important. Depression is important, treatment of depression is important, follow-up, screening someone for suicide, prescribing the right treatment for them is important, and then trying to get them into a point of remission is also important. The problem is, if for a performance measure, if it doesn't measure what it set out to measure, then you can't support its validity. So when you look at the 4 metrics that are looking at progression towards remission or hitting remission, since there's no evidence that's in the literature that says 6 and 12 months are these important time factors that improve outcomes for patients in depression, it's not a valid scoring. It's a random time factor that is being chosen. For the validity of, say, the one that talks about treatment, when you look at that, it's still not measuring what you want it to measure, given that there are treatments that are non-pharmacological, such as talk therapy, and there's no real way to measure that. So you have this metric that you've set up, and you've designed it to measure something that it's not measuring. And that's when we say that it hasn't met the mark. And then we look at 3 levels of attribution. So was this particular performance measure, and we do this for all of them, measured at the level of the individual physician, a group practice, so all of the members of your group, or a healthcare plan. And there are lots of different reasons to measure a particular measure at one of those or multiple levels. But if there was no data to support it, then we couldn't say that it was a measurement that should be in practice. I think performance measures in general are a challenge to create. Right now, in electronic health records, there are areas that have discrete data, meaning plug in numbers or click the box, which can be recorded and turned into some kind of a report. But a lot of what happens with the patient in the room is either free text or written out, and therefore is a little more challenging to collect. And then to collect that data, it's very burdensome on the physicians who are trying to see the patients. So in general, that's one error with performance measures. Another performance measure issue in general, but of course also with depression, is we see a clinical situation, scenario, condition that is really important, that we all want to do better at treating and improve outcomes. And sometimes we jump in, not we meaning us or the ACP or the physicians, but an organization that creates a metric. And they jump in because they want to be able to say we're providing care that's good to our patients, and we're monitoring that sort of as a service to society. But they do it without the evidence behind it. Those 2 problems are the main problems here with the depression performance measures. I think as we learn more about depression treatment and that pharmacotherapy is not the only way to do it, measuring a treatment outcome is going to remain challenging, especially given that you don't need to do a referral for that patient. Medication adherence is a challenging performance measure, whether it's for depression or something else. I understand the importance of treatment and continuing treatment, but again, we don't want to insert performance measures into the patient-physician relationship in a way that it creates negative tension. We know that the primary care physician patient relationship has been studied and proven to increase quality of life, longevity, and decrease morbidity. And so we don't want to put something in between that strains it. So you really shouldn't have a performance measure that is antagonistic. If I'm required to have a patient on something for 84 days and my patient stops it, I should not feel the pressure to push them to take that. My job should be Why did we stop it? Are you feeling better? Was it not working for you? Did you have side effects? Should we try something else? And as soon as you insert those sort of mandates into a performance measure, it can really alter the therapeutic relationship between the patient and the physician. So those are some of the challenges specifically with depression. I will also say depression still carries a stigma. There are some cultural and gender stigma that go with depression. Patients sometimes don't want treatment, or they feel that needing or requiring treatment is a sign of mental and physical weakness, which we know is not true. It is really hard for patients and the layperson to understand that many mental health conditions have a biological source or cause. They might have been genetically predisposed to it, just like high blood pressure. So depression in general does have some extra hoops to jump through to create, valid and sound performance measures. Wow, it's a lot of work to look at all of the data that is out there. We use the RAND criteria, which is a more stringent criteria, to say, is there an agreement for this or not? There's personal interest, personal bias that we have to learn to put aside, which is always a challenge. This particular paper was really challenging because, as you see, we all scored it as very important, and we want there to be good metrics so that patients get treatment and we have a way to know how we can do better. So I think our hearts were in it. Like, we really wanted to be able to approve that as many measures as we could, but you have to put that aside and say, but is there sound evidence? Was this looked at and studied in the manner that this performance measure was written, so that we can say to our physician colleagues, no, you can trust this? And so those are some of the challenges. It is a lot of work. It's hours and hours of review, hours and hours of arguing back and forth, and really picking apart the data. We do it as a group so that we can sort of hold each other accountable and make sure that we're looking at all angles of it, from clinical care to the ethical considerations, and that we're not allowing our own bias to sink in. And then you have to get all the physicians and the staff on board when we write the paper to agree on the wording and how we present it. I think there are a lot of ways that the screenings can be approved. There's, a discussion of it in the paper, but making sure that if you're going to use something, say, that's time definitive, where's the evidence? If the evidence isn't there, then looking for the evidence. I think looking at the progression towards remission, one of the points that was really important to me was a 50% reduction, say, in symptoms would at least tell you that the patient was feeling better and, getting back to life. Or, using allowing more valid measures. For example, yes, the PHQ-9 is a valid assessment for depression symptomatology and severity, but there are geriatric screening tools as well that are more accurate for patients who are 65 and older. So allowing more than one tool that is valid, and that flexibility in the clinical situation to use the one that is most appropriate to the patient in front of you. And that's just some examples of how it could be better. I mean, I think I said it, but if I was going to summarize, I think that the idea of performance measures helping us close gaps in patient care have potential as a really valid tool to identify where across the country, maybe there's something in our healthcare system that is preventing us from providing excellent care. But we have to be very careful in how we use these. Looking at past performance measures, there was a study done that said only about a third of them had the validity behind them or the evidence behind them to make them worth considering for use. And what we have to be very careful about doing is using what is out there and easy just because we want something. Because if it's not valid, then there's a lot of distrust in the system. And if we're going to report out quality of care or hold people to a standard, then that standard has to be steeped in evidence.